Hello everyone. So in this video on obstetrics, we'll be talking about second stage of labor, and we'll be talking about the events that are occurred in second stage of labor. We will talk about clinical course, and finally we will talk about management in the second stage of labor. So second stage of labor begins with the complete dilatation of the cervix, and it ends with the expulsion of the fetus. And this stage is concerned with the descent and delivery of the fetus through the birth canal. The second stage has two phases, namely, one is propulsive phase that include from the full dilatation of cervix until the head touches the pelvic floor, and the expulsive phase, since the time mother has irresistible desire to bear down and push until the baby is delivered. And with the full dilatation of the cervix, the membranes usually rupture, and there is escape of good amount of lycoramni, and the volume of the uterine cavity is thereby reduced. Simultaneously, uterine contraction and retraction becomes very stronger, and the uterus becomes elongated during the contraction, while the anterior, posterior, and transverse diameter are reduced. And the elongation is partly due to contraction of the circular muscle fiber of the uterus to keep the fetal axis straight. And this delivery of the fetus is accomplished by the downward thrust offered by the uterine contraction, supplemented by the voluntary contraction of abdominal muscle against the resistance offered by the bony and soft tissue of the birth canal. And there is always a tendency to push fetus back into the uterine cavity by the elastic recoil of the tissue of vagina and the pelvic floor, and this is effectively counterbalanced by the power of retraction. Thus the so that's why the with increasing contraction and retraction, the upper segment becomes more and more thicker with the corresponding thinning of lower segment. And with the power of retraction, the fetus is gradually expelled from the uterus against the resistance offered by the pelvic floor. And after the expulsion of fetus, the uterine cavity is permanently reduced to the size only to accommodate after birth. And the expulsive force of the uterine contraction is added by the voluntary contraction of the abdominal muscle called bearing down effort. So talking about clinical course, what are the clinical events that occurs in second stage of labor? The second stage, as we all know, as we just said, it begins with full dilatation of the cervix and end with the expulsion of the fetus. So there will be, first of all, there will be the pain. The intensity of the pain increases. The pain comes at interval of 2 to 3 minutes and lasts for about 1 to 2 minutes, and it becomes successive with increasing intensity in the second stage. And second one is bearing down effort, and it is the additional voluntary expulsive effort that appears during the second stage of labor, that is expulsive phase, and it is initiated by nerve reflex, also known as Ferguson reflex, set off due to the stretching of the vagina by the presenting part of the fetus. And in the majority, this expulsive effort starts spontaneously with full dilatation of cervix along with the uterine contraction. The woman is instructed to exert downward pressure as done during the straining at stool, and the sustained pushing beyond the uterine contraction is discouraged, and the premature bearing down effort may suggest uterine dysfunction, and there may be slowing of the fetal heart rate during the pushing, and it comes back to normal once the contraction is over. And next we have the membrane status. The membrane may rupture with the gush of liquor per vaginum, and the rupture may occasionally be delayed till the head bulges out through the introitus, and rarely spontaneous rupture may not take place at all, and allowing the baby to born in the skull. And the descent of fetus. The feature of descent of fetus are evident from the abdominal and vaginal examination. The abdominal findings are progressive descent of the head, axis in relation to the pelvic rim, the rotation of anterior shoulder to the midline, and uh, the change in the position of the fetal heart rate is shifted downward and medially. The internal examination reveals the descent of head in relation to the scale spine, and gradual rotation of the head evidenced by the position of the sagittal suture and the occiput in relation to the quadrant of pelvis. After that, we have the vaginal sign. As the head descends down, it distends the perineum. Vulval opening looks like the slit through which the scalp hair is visible. And during each contraction, the perineum is markedly distended with the overlying skin tense and glistening, and the vulval opening becomes circular. That is expulsive phase. And the adjoining anal sphincter is stretched, and the stool comes out during contraction. The The head recede after the contraction passes off, what it is held up a little in advance because of retraction. Ultimately, the maximum diameter of the head biparatal stretches the vulval outlet, and there is no recession even the contraction passes off, and this is called crowning of the head. And the head is borne by the extension, and after a little pause the mother experiences further pain and bearing down effort to expel the soldier and the trunk, and immediately thereafter the gush of liquor hindwater flow follows, and often it is tinged with blood. The maternal signs, there are feature of exhaustion, and respiration is slowed down with the increased perspiration, and during the bearing down effort the face becomes congested with neck pain prominent, and immediately following the expulsion of fetus the mother heaves a sigh of relief. In the fetal effect, the slowing of the fetal heart rate during contraction is observed, and which comes back to the normal before the next contraction. And talking about management of second stage of labor, the transition from first stage to second stage is evidenced by the various following features like increasing intensity of uterine contraction, bearing down effort, and urge to push or defecate with the descent of presenting part, and complete dilatation of cervix as evidenced on vaginal examination. The principle of management is to assist in the natural expulsion of the fetus slowly and steadily, and to prevent perineal injuries. And the preparation for delivery, the first of all, talking about general measures of the management, the patient should be in the bed, the constant supervision is mandatory, and the fetal heart rate is recorded at every 5 minutes, and the to administer inhalation analgesic if available in the form of nitrous oxide or oxygen to relieve pain during contraction. And the vaginal examination is done in the beginning of the second stage, not only to confirm its onset but also to detect any accidental cord prolapse. And the position and the station of the head are once more to be reviewed, and the progressive descent of head is ensured. And the preparation for delivery, and the position of the woman during delivery may be lateral squatting or partial sitting for 45 degree. The dorsal position with 15-degree lateral tilt is commonly favored as it avoids autocabal compression and facilitates the pushing effort. The leg holders or stirrups may be used, and upright position, sitting, kneeling, squatting, or dorsal had no advantage over recumbent one. Upright position increases the blood loss, uh, and the the second is degree perineal laceration. However, it is associated with less episiotomy, less fetal heart rate pattern, and less pain reduction in duration of second stage labor. And prolonged sitting position in second stage may cause neuropathy of the common perineal nerve. So the best method is the dorsal position with 15-degree left lateral rib, that is commonly favored. And we have the accuser scruffs off, and that is puts on sterile gown, masks, and gloves, and stand on the right side of the table. And the toileting of the external genitalia, the and the inner side of the thigh is done with cotton swab soaked in Savlon or Dettol solution, and one sterile sheet is placed beneath the buttocks of the patient and one over the abdomen. And the sterilized leggings are to be used, and essential aseptic procedure are remembered as 3 C's like clean hand, clean surface, and clean cutting and ligaturing of the cord. 3C: clean hand, clean surface, and clean cutting and ligature of the cord, and the to catheterize the bladder. In the next management step, we should do the conduction of delivery. The assistance required in the spontaneous delivery is divided into 3 phases, like that for the delivery of head, delivery of the soldier, and the delivery of trunk. The principle followed in the delivery of head are to maintain the flexion of head to prevent its early extension and to regulate its slow escape out of the vulval outlet. And the patient is encouraged for the bearing down effort during the uterine contraction, and this facilitates the descent of the head. And when the scalp is visible for about 5 centimeter in diameter, this flexion of head is maintained during contraction, and this is achieved by pushing the occiput downward and backward by using thumb and index finger of the left hand, while pressing the perineum by the right palm with the sterile vulval pad. And if the patient passes stool, it should be cleaned and the region is washed with a septic lotion. And this process is repeated until subsequent contraction, until the subocciput is placed under the symphysis pubis. The guarding the perineum hands-on perineal massage is recommended according to WHO, and at this stage the maximum diameter of the head biparietal diameter stretches the vulval outlet without any recession of the head and even after the contraction is over, and this is called as crowning of head. And the purpose of increasing the flexion of head is to ensure that the smallest sub-occipital frontal diameter 10 cm distance the vulvar outlet instead of larger occipital frontal diameter of 11.5 cm. This is picture showing the crowning of the head. That is the maximum diameter of the head. The biparietal diameter stretches the vulvar outlet without any recession of the head even after the contraction is over, and this is called as crowning of the head. And when the perineum is fully stretched and threatens to tear, especially in the primary gravity, episiotomy is done at this stage after prior infiltration with the 10 ml of 1% lignocaine. The bulging, thinned out perineum is better criterion than the visibility of 4 to 5 cm of scalp to decide the time of performing episiotomy. And the episiotomy is done selectively and not as the routine procedure. And the slow delivery of head is in between the contraction is regulated, and this is done. Here the slow delivery of the head in between the contraction is to be regulated, and this is done when the sub-occipito frontal diameter emerges out, and this is accomplished by the something known as a Ritken's maneuver. What Ritken's maneuver is this that the slow delivery of head is accomplished by pushing the chin with the sterile towel. The pushing the sorry pushing the chin with a sterile towel covered fingers of the right hand placed over the anococcygeal region, while the left hand exerts pressure on the occiput, and this is known as Ritken's maneuver. And the forehead, nose, mouth, and chin are thus borne successively over the stretched perineum by extension. And what are the care following the delivery of head? The immediately after the delivery of head, the mucus and blood in the mouth and pharynx are to be wiped off with sterile gauze piece on the little fingers. Alternatively, the mechanical or electrical sucker may be used, and a simple procedure prevents the serious consequence of the mucus blocking the air passage during the vigorous inspiratory effort. And the eyelid are then wiped out with the sterile dry cotton swab using one for each eye starting from the medial to the lateral canthus to minimize the contamination of the conjunctival sac. The neck is then palpated to exclude the presence of any loop of the cord, and if it is found if loose enough, it should be slipped off over the head or over the shoulder as the baby is being born. But if it is sufficiently tight enough, it is caught it between the two pairs of cochers forceps placed 1 inch apart. And to prevent the perineal laceration, we have to pay attention to the various things like delivery by the early extension is avoided. The flexion of the subocciput comes under the symphysis pubis so that a lesser suboccipito frontal diameter emerges out from the introitus, and the spontaneous forcible delivery of head is to be avoided by assuring patient not to bear down during contraction, and to deliver head in between contraction, to perform timely episiotomy if indicated, and to take care during delivery of soldier at as the wider biacromial diameter emerges out of the introitus. And nextly we will discuss about deal with the soldier. It is just like a story, just you can just listen and enjoy, not to be hasty in the delivery of the soldier, and wait for uterine contraction to come for movement of the restitution and external rotation of head to occur. Okay, we will see through the picture. Okay, this picture shows the head is borne by extension. Head drops down. This is a head drops down with the face close to anus. The restitution, external rotation. So during the contraction, the anterior soldier is borne spontaneously behind the symphysis. If there is delay, head is grasped by the both hand and is gently drawn posteriorly. Anterior soldier is released and released from under the pubis by drawing the head in upward direction. The uh, the posterior shoulder is delivered out of the perineum, and the traction of the head should be gentle to avoid excessive stretching of the neck causing injury to brachial plexus, hematoma of neck, or fracture of clavicle. Hooking the fingers in the axilla should not be done to avoid the injury to the brachial plexus. Finally, we have to do the delivery of the trunk. After head soldier, and we have to do the delivery of the trunk. After the delivery of the soldier, the forefinger of each hand are inserted under the axilla, and the trunk is delivered gently by the lateral flexion. Uh, After that, we have to do the immediate care of the newborn. The once the fetus is delivered, soon after delivery fetus, it should be placed in the tray covered with the clean dry linen with the head slightly downward. It facilitates the drainage of the mucus accumulated in the tracheobronchial tree by gravity, and the tray is placed between the legs of the mother and should be at the lower level than the uterus to facilitate the gravitation of the blood from the placenta to the infant. Air passes, the oropharynx may be cleared of the mucus and the liquor. The bulb, syringe, or suction catheter aspiration may be used. And the FGAR rating at 1 minute, and at 5 meter is to be recorded. The clamping and ligature of the cord is clamped by the two coulter forceps, and the near one is placed 6 to 10 centimeter away from the umbilicus, and it is caught in between. Two separate ligatures are applied with the sterile cotton thread 1 centimeter apart using the NIF knot, and the proximal one being placed 3 centimeter away from the navel. The squeezing the cord with finger prior to applying ligature or plastic cord clamp. The squeezing of the cord with fingers prior to the applying ligature or plastic cord clamp prevents the accidental inclusion of embryonic remnant. Here we have the picture of the cord clamp. It is made of the plastic and supplied in a sterile pack, and it is serrated surface, and the lock is made it's film grub film. It occludes the umbilical vessel effectively, and the cord clamp is kept placed until the it falls off together with detached stump of the umbilical cord. And we have to do the delayed cord clamping for 2 to 3 minutes or till the cessation of blood cord pulsation to facilitate transfer of 80 to 100 ml of blood from compressed placenta to a baby when placed below the level of umbilical, when placed below the uterus. And finally, we have to do the quick check image to detect any gross abnormality, and the baby is wrapped with dry warm towel, and the identification tape is tied both on the wrist of the baby and the mother. And once the management of third stage is over, baby is given to the mother or to the nurse. Now in next video we will be talking about third stage of labor. Thank you. Till then, keep revising, and we will meet in next video.